Thank you so much for this time. A huge thank you to our organizers and Dr. Jazzy especially for making time for symptom management. We're all about taking care of the whole person. It's so much more than the lump in the breast or the mass in the kidney. And so in that way, I look forward to giving you a guided tour of 4 studies that were presented at ASCO, some of which had some key takeaway points for our awareness on what's happening out there, and some of which do have practice-changing implications. We can never have too many platforms to talk about how we can actually take care of that whole person with cancer. Where am I pointing? Oh, over there. Okay, good. So when we're talking about how we're going to actually approach this, we have to start with looking at the treatment-related toxicities and then the care of the survivors. So the first part we're going to talk about are 3 studies that are on treatment-related toxicities. The very first one is on CIPN, chemotherapy-induced peripheral neuropathy, in patients who have breast cancer and who receive weekly paclitaxel without that limb cooling. The incidence rates are upwards of 36 to 45%. A substantial portion of the patients are affected by CIPN. There are studies that show the impact of limb cooling. We're going to talk a little bit about that. But we need that confirmatory, that study that's going to be the one that's quoted and where the case is made both for clinical practice change, but also to our payers. And so the short version is this is not that study. We're still waiting for that. But we're going to talk about why this study is important, and more importantly, why we need the collective clinical voice to actually help prioritize what we should measure and how we should measure it. And so this fantastic group from the Cancer Institute Hospital in Japan presented this RCT where they looked at the impact on CIPN of a particular limb cooling apparatus that they have from a company based in Japan. And their target patient population were patients with breast cancer who were receiving weekly paclitaxel in the perioperative period. And so when they looked at the randomization, they opted for these 2 arms. The experimental arm was 13 degrees Celsius. This was based on previous reports. That was their rationale and logic behind that. And then the control arm, they opted for 25 degrees Celsius. I had to ask Google to tell me what that is in Fahrenheit. It's about 77 degrees Fahrenheit or so. And so that was chosen as the control arm so that there's, of course, to maintain the blinding and it was assumed that 25 degrees Celsius would have limited actual therapeutic effect in this context. And so they went on to, when they designed the primary endpoint, they picked this particular questionnaire, the PNQ, which is the Patient Neurotoxicity Questionnaire. And they picked it as a PNQ of greater than or equal to grade D. Grade D is the patient report of moderate symptoms that interfere with their activities of daily living, moderate symptoms that interfere with activities of daily living. As secondary endpoints, they also included other grading mechanisms, patient-reported as well as clinician deemed, if you will, that are second nature to so many of us who read toxicities of trials, CTCAE, as well as the PRO CTCAE. And so in the context of how they designed and implemented the study, well, you get a sense of what it looks like. The temperature was preset. Nobody could see what it actually was. So that was how they maintained the blinding in this particular apparatus. And this was a continuous one. There was no temperature variation during the time that it was on. So, what did they show? We'll start with the safety and adherence outcomes first. Patients were okay with keeping this on. This may sound simple, but the fact is the last big study that came out of this in this space, the Polar trial, patients had to put their hands inside gloves that were frozen to 0 degrees Celsius. And so it's important to recognize the importance that adherence plays up front before we even know if it works or not. So in the control group compared to the experimental group, 82 to 88% were stayed adherent with this regimen. Those who discontinued were actually because they stopped paclitaxel for one reason or another. So it'd be pretty silly to keep your hands in the gloves every week if you're no longer on the treatment. But nevertheless, no frostbite, no severe AEs. One person in the experimental arm, the 13 degrees Celsius arm, reported a grade 1 cold sensation. So, what about their primary outcome, which was this patient reported neurotoxicity of grade D or above, where it's at least moderate symptoms affecting their ADLs. The distribution of patients with this grade of neurotoxicity was not statistically significant between the control arm and the experimental arm. This is through their treatment with the weekly paclitaxel. That was the primary endpoint, was at when they completed their weekly paclitaxel. Interestingly, at 3 months down the road, after completion, what they did note was that the patients who were in the experimental arm with the 13 degrees Celsius cooling, there was what seems like a paradoxic report of 32% had reported a higher percentage of high-grade neurotoxicity. This is both statistically significant as well as clinically significant. And it's very hard to make sense of the why. Even more so when we look at it in the context of the studies that were being done before. And so the current state of cryotherapy in cancer care, when you look across the guidelines, it ranges from no recommendations to it can be considered. And so this study doesn't necessarily move us any closer to a definitive answer. And that's partly because of two main issues. You see on the right a list of studies that were done in recent years looking at some form of limb cooling and its impact on CIPN. And you see that the endpoints, the primary endpoints that were picked by these studies. It makes for a very difficult environment to try to make sense of one type of intervention's impact versus another. You also see how the findings were mixed. Sometimes the reduced incidence was very compelling, but it's also one where it's very hard to use data from across these studies because of different endpoints that were chosen, but also of different temperatures that were chosen, of different rates and time periods where temperature exposure happened. This is all to highlight a very stark reality we live in the non-pharmacologic side of cancer research and as well as cancer practice, when we don't have a set design for dose escalation and dose expansion, a dose finding trial. What you end up with are what are the equivalent of a phase 3 RCT when we don't even have a phase 1 for that particular non-pharmacologic intervention. And so the main takeaway for me when looking at this study and looking through a clinical as well as a research lens is the opportunity to have consensus, to reach a consensus driven by frontline clinical teams on what are the outcomes that we need to make, that must be the primary outcome, and what needs to be the first secondary outcome. That will allow, actually, us to make sense of what were years of studies that now live in they live in their own independent silos, if you will. And so in this particular study, we don't get any closer to a definitive answer. It raises more questions than answers. But it also tells us how it's that decision to use any type of limb cooling apparatus as part of the treatment experience, if you will, it will be a very individual one and not one that's rooted in robust enough evidence. Continuing down the journey of treatment-related toxicities, the next compelling study was on radiation-induced nausea and vomiting. And so this was a study out of this team in India, and they did this phase 3, RCT, placebo-controlled, on adding olanzapine to a backbone of a 5-HT3 agonist. They used ondansetron for the prevention of radiation-induced nausea and vomiting, RANV. So depending on which series you look at, the incidence is anywhere from 40 to 80%. Make no mistake, grade 1 nausea is uncomfortable. It's not a low-grade toxicity. So when you look at an incidence rate this high, particularly with abdominal and pelvic radiation, you also notice that there's a constellation of symptoms that go with this nausea and vomiting picture. Now, we don't know what came first. Is it a lack of sleep that came first? Is it the nausea that came first? The loss of appetite that came first? But when you're looking at it from the patient's perspective, it's who cares what came first? I'm feeling all of these, and I don't want to feel any of them. And so this particular study, it's a double-blind RCT. It was done over a period of 3 years at a very large tertiary care hospital located in the city of Kochi in India. And they picked patients who were slated to receive radiation. And they looked at the intervention was, the randomization occurred to the standard group, which was ondansetron plus placebo, and the experimental group, which was the same ondansetron 4 milligrams twice a day, plus olanzapine 5 milligrams once a day. And then they assessed the standard safety, efficacy, and both total quality of life as well as emotional symptom burden parameters that you see there. And so they enrolled, they looked at about 683 patients and were able to get consent and randomize 306. And it was 1-to-1 randomization. And so let's look at what they found. The patient distribution by characteristics was about the same in both arms. Similarly, with the distribution of cancer type, the site of radiation, the dose of radiation therapy were all comparable, not statistically significant by both arms. And so when we look at the incidence of nausea, so the proportion of patients who reported any nausea, you look in the red, the standard group, the proportion that said yes, or who had one or more episodes of any nausea, 83.6%. And then you look at the experimental group, that had that same ondansetron background, but with olanzapine 5 milligrams once a day added, the incidence of any nausea was at 14%. This was highly statistically and clinically significant. Now, what about high-grade nausea? So when you clumped the people who didn't have any nausea or had grade 1 nausea, what about grade 2 and above? In the standard group, 67% had grade 2 and above nausea compared to 7% in the experimental arm. What about vomiting? Vomiting incidence in the standard group, 25.5%, in the experimental group, 4%. Highly statistically and clinically significant. And then when you look at significant vomiting, grade 3 and above, it was 7% in the standard group and 1.4% in the experimental group. And so this is, the previous numbers you saw were purely incidence, right? You could have anywhere from 1 episode or 30, and you would still be counted as 1 in the previous calculations. Here, what you're seeing is the frequencies. What were the proportion of patients who had 15 or more versus, more than 15 or 15 or less? And you see from the standard group and the experimental group, if you compare across the lines, is you see that the proportion who had less than 15% was 16 in less than 15 episodes was 16% in the standard group compared to 2% in the experimental. And then similarly, The proportion of patients who had more than 15 vomiting episodes was 9.2% in the standard group and 2% in the experimental. All significant and clinically relevant. What about the types of concurrent treatment they received with the radiation? Did it make a difference if they received concurrent chemotherapy or no concurrent chemotherapy? And what you see is that among the patients who did receive concurrent chemotherapy, the intervention arm with the addition of olanzapine 5 milligrams still fared a lot better. Here you see that the high-grade nausea in the intervention arm with the olanzapine 5 milligrams is 6.3% compared to 86% in the placebo arm. And similarly, when you look at patients who did not receive concurrent chemotherapy, you can see that the incidence of high-grade nausea was still lower in the experimental group, significantly, 8.7% in the experimental group compared to 42% in the standard arm. The adverse events that occurred during radiation, this was the first toxicity slide was about in the context of the radiation itself. Well, you see the incidence of nausea and vomiting much higher in the standard compared to the experimental group. The standard group also had a lot more gastritis than the experimental arm that received the added olanzapine 5 milligrams compared to the placebo. So nearly 40% in the standard group compared to 21% in the experimental group. What were the toxicities that may be specific to the intervention at hand, which is the olanzapine 5 milligrams? Orthostatic hypotension was reported, dysarthria, drowsiness, elevated prolactin. These were consistent with what had been previously reported in other studies that looked at olanzapine for nausea. And so what about the whole person, right? Okay, we talked about nausea, we talked about radiation, where they're getting it and how, but what about the other symptoms, the co-occurring symptoms? Those who had the olanzapine 5 milligrams, their anxiety score, their mean anxiety score over the course of treatment actually went down. Compared to the first line in red that you see, the standard group, their mean anxiety score went up over the course of treatment. So what you see is not just a reduction in the slope of a symptom, you actually see a reversing of the course. Similarly, when they looked at the mean depression score, the exact same trends were seen. And they were both statistically and clinically significant, where the standard group had an increase in the mean depression score compared to the experimental group, which had a reduction. And so when they looked at the other scales of quality of life that they measured, emotional function did have a significant difference. The first column that you see where there's the teal arrow, the 9.87, is the change in the quality of life score within the experimental arm. Compared to the number in red that's pointed out, 5.25, that's the change in the quality of life score in the olanzapine arm, meaning your overall quality of life, and specifically your emotional functioning quality of life score, didn't get as bad as it did in the arm that didn't get olanzapine. And then when you look at the other co-occurring symptoms, you can see that insomnia and loss of appetite also favored strongly the arm with, that received olanzapine. So, key takeaways from this particular study: ondansetron is the backbone of antiemetic management for patients who are receiving abdominal and pelvic radiation therapy. This study makes a compelling case for adding olanzapine 5 milligrams once a day as part of the standard regimen for prevention of RANV. And the study also shows us the toxicity profile and what to look for in clinical practice And it also shows us the co-occurring symptoms that could be impacted favorably for patients who have olanzapine added. And so this is one of these supportive care studies that actually does have practice-changing potential and practice-changing impact for patients receiving radiation therapy and adding olanzapine to their 5-HT3 backbone. The last two studies I'm going to talk through very quickly, and these are in the integrative oncology space. First is chemotherapy-induced thrombocytopenia. You all know the rates can be anywhere from 22 to 60%. Current approach, dose delays, dose modifications, transfusions, thrombopoietic agents, if you can afford them and have access to them. We don't fully know the impact of CIT on overall patients' disease outcomes. So this particular study, which was part of the oral abstract session for the Symptom Science and Palliative Care track, looked at the carica papaya leaf extract. There's enough preclinical data to show that preclinical and clinical data show that it can impact the platelet binding and the platelet count, but there wasn't clinical evidence per se. And so this particular study out of this group, also based in India, they asked, is the platelet recovery for a patient who has chemotherapy-induced thrombocytopenia, is the platelet recovery somehow faster if you take this carica papaya leaf extract? By the way, this was done. This product was also chosen not just for the reasons you see up there, but because it was a part of how they had managed dengue-induced thrombocytopenia in this part of the world. And so there was clinical evidence, regional clinical evidence, that it can help platelet recovery. And so this particular study, led by Dr. Ostwal over at Tata Memorial, the PACT study, was exactly for that. CPLE versus placebo for chemotherapy-induced thrombocytopenia. And they wanted to assess if the platelet counts would recover faster compared to the placebo arm. And so randomized phase 3 across 2 centers, patients with solid tumors. Entry criteria was your platelet count needed to be below 75, and who had received at least 2 prior cycles. And so the patients were matched to placebo, randomized to placebo, or CPLE, 1,100 milligrams by mouth 3 times a day. And it continued until your platelets recovered, or 10 days, whichever was shorter. And so the randomization occurred. Patients who came to the outpatient for their routine pre-cycle clearance, if they met the criteria and they had particularly that CBC that showed the platelet less than 75, that was the trigger for screening for the study. And so when we look at their findings, I'll jump straight to their findings. They randomized 219 patients, and they had similar age and gender characteristics. The cancer characteristics themselves were also not statistically significant. What they did show, though, was that the patients who were in the treatment arm with CPLE, their recovery at day 4, the proportion who recovered at day 4 was 64% of patients recovered from having a platelet count below 75,000, compared to 48% of the placebo arm. And so the study had met its primary endpoint by day 4. Clinically significant, 16% recovered faster with this particular extract. Adverse events, there were none reported with the CPLE. There was a bleeding in the placebo arm, no thrombotic events in either arms. And so you have a natural extract that is cost-effective, it's accessible, no particular adverse events. We don't have the long-term data on what are the implications beyond that immediate recovery period, not just on outcomes, but also pharmacokinetics and pharmacodynamics. And that goes into the last point here related to regulatory oversight of herbal treatments, is those standard points of data that we would look for with any drug treatment study, we simply don't have a framework for vetting what look like promising options, particularly in resource-limited environments, for assessing whether a extract that shows activity that's been used in other clinical settings, dengue, whether it can be fully integrated into cancer care. And then I'll take about 30 seconds and run through the last study. This is looking at another integrative intervention in cancer survivors, anxiety. 1 in 2 cancer survivors have report anxiety after completion of their cancer treatments. 2/3 take 5 or more medications after completion of their cancer treatments. And so we know that the prevalence of anxiety and the constellation of symptoms that go with it are part of the reality that cancer survivors face. So this particular study out of the integrative oncology group at Memorial looked at music therapy and looked to establish its non-inferiority compared with CBT for the for the treatment of anxiety in cancer survivors. This was a comparative effectiveness trial. And CBT is a first-line treatment. Music therapy actually has a place in the Society for Integrative Oncology joint guidelines with ASCO on the management of anxiety, right up there with your friendly neighborhood SSRIs. And so that was their hypothesis. They wanted to show that music therapy is non-inferior to CBT, first-line CBT, the MELODY trial. I mean, seriously, the acronym game was at an all-time high at this ASCO. So we get the message. We have to come up with even better ones. And so here's the intervention. CBT for 8 weeks compared to music therapy for 8 weeks, and then follow up until 26 weeks. Each intervention, CBT was delivered by licensed mental health clinicians. Music therapy, board-certified music therapists. And so they looked at the primary outcome of anxiety severity, looking at the HADS, specifically the anxiety subscale. Standard methodology. They randomized 300 patients, more or less equally. And then they looked at the results. So the mean decrease in anxiety and the mean difference in decrease in anxiety within the group that got music therapy and the group that got CBT were equivalent. There was no statistically significant difference in the mean reduction compared to the two groups. That established the non-inferiority of music therapy compared to CBT. Both groups did have a reduction in their anxiety from before and after their respective interventions. That confirms what we already know, is that these are two interventions that are that are effective at reducing anxiety levels over time. And so the point of this is a number of different things. But first is that the evidence base for integrative approaches is growing. And comparative effectiveness research, but also primary efficacy research is the way to go for non-pharmacologic interventions. And it's taking something like music therapy out of the more casual space and bringing it into the space of our armamentarium for taking care of the whole person. And so that was as fast as I could go for this guided tour through symptom science research at ASCO. All right, I'll pause there.
I'll ask a question. Do you think people may be a little more receptive to the music therapy, CBT result if you'd had a control arm?
Right, so this is interesting, right? So it's what should be the control arm based on the current state of evidence versus what should be the control arm based on the current state of practice. So we have this, I would butt heads in an academic way with my chair constantly. Because that control arm, if your survivors are not getting CBT, they are not getting any formal mental health care, then one can argue that the control arm actually should reflect what the current state is of practice, versus how this study was designed, which was, well, we already have evidence that shows that CBT versus usual care, CBT is superior. And therefore, the usual care, first line per the guidelines, is CBT. When in fact, in reality, that's really not what happens.
But I think most people don't get either.
Yes.
And their anxiety level often does go down on its own, either by reassurance from the physician or just some time passes, or they're getting actively managed. And so their anxiety levels can come down in the absence of either intervention. I'm not saying they come down as much, but it might be nice to have a no intervention arm to maybe make it a little more sellable to payers or anyone else for that matter.
So the CBT versus usual care did show that. For a proportion of people, your self-reported anxiety levels does come down over time. It was just much greater for the CBT arm. So it is the accelerant for recovery. So in that way, what would be an extrapolation would be is if music therapy is non-inferior to CBT, does that mean it would also be non-inferior to, not non-inferior, superior to usual care? But yes, that should definitely be studied. But doing nothing is, we already know that doing nothing is not enough. What else?
These were wonderful studies. They were so interesting. I like that the first study was a negative study, and you highlighted that that means it needs to be more individualized. But as we hopefully get more negative studies published, as we have already, and hopefully will continue, how do you feel that the ASCO guidelines, other guidelines, should be updated to reflect that, and how do you use that in your own guidance for patients?
So I love a good negative study. There were a couple actually presented at ASCO and again at ASCO Quality that were, I learned more from the negative study than I did from the positive studies that were presented. And without a doubt, we need a space to discuss what doesn't work, especially in the realm of non-pharmacologic interventions, behavioral interventions. There were a couple of studies on remote symptom monitoring that did not work. They did not meet their primary endpoint. And so it was crucial to understand what exactly they did that didn't work, because what they did that didn't work is actually what some health systems are doing right now. And so it was very important for the negative studies to inform what we should not be doing. There has to be more space in the guidelines. So I've served before on the NCCN's Older Adult Oncology panel, and then I'm a member of ASCO Supportive Care Guidelines Advisory Committee, or Guidelines Advisory, yeah, I got the acronym right. And so we have to actually put what doesn't work as part of the top line recommendations. At least what the studies up to this point showed don't work. And so that's always going to be a push and pull, and it's entirely dependent on who's on the panel. The words that are in those guidelines are so dependent on who's on this panel. So if you have any interest in volunteering for any of those guidelines panels, please register on the ASCO volunteer website. That's the first way to put in your interest so that you can be pulled for participation on these panels. So if you see more of the what not to do, please know that I was one of the voices behind that. What else?
So, yeah, nice to see you again.
Good to see you, Arturo.
So, question about the music therapy. So, is there any specific, we don't have music therapists in our center, so I have no idea how that works, like who pays for that, how we get it implemented. In my prior institution, CTCA, before we taken on City of Hope, they did everything, right? Acupuncture, you get in, you got a spa, you got everything you wanted. That's why they went bankrupt, and then they were sold out, right? So how can we make this, music therapy, affordable and feasible? Should we just put it in the chemotherapy, infusion chairs? People just listen into it, like when people are in the airport or on an airplane, and they're just going to like check on the specific, songs or things they want to listen. Should we start implementing some of that to at least see some, benefit? Maybe one, you have 3 infusion rooms. One has the music therapy, the one doesn't. Maybe we can try it out like that and just download an iTunes channel or something. Because I'm always very curious about it. So I don't know your thoughts about how you implementing this music therapy as a something that we can actually prove. Because CBT, I don't refer my patients to CBT. I mean, I just don't. I just try to give them comfort myself. Talk to the families, and that gives them anxiety, relief to some extent, and maybe also with some olanzapine that we give them. So, but just curious about what your thoughts about and how implementation is going to be, meaningful for this.
I've always valued having Arturo as a colleague in oncology because we're thinking on the same lines, which is always about the practicality and the implementation science of it. Who cares if you have a plenary at ASCO if absolutely no health system has actually implemented this in a systematic and meaningful way? That 15-year gap between evidence and implementation was for treatments, right, like drugs. Behavioral interventions, snowball's chance in hell. Sorry. And so the point is, what we need that we currently don't have, but that we're actively working to influence, is study design that takes into account the setting of the intervention's delivery. So these music therapists, they were certified music therapists, and they had dedicated sessions with the patient. In the world of practical day-to-day life, the study we would need is usual care compared to usual care plus music therapy with a live person compared to usual care plus the music therapy that's shaped through an app or a tech intervention, a low-touch approach. And so I'm completely with you. These are the studies we need. I'm about to take on a responsibility to actually design integrative oncology studies practical integrative oncology studies. And that's going to factor very heavily into that. So
I know you will, too.
We're going to do this.
You'll see another session on that in the future, for sure.
Here, here. And these all make a difference, by the way. The outcomes that we measure are not, the outcomes we measure are fundamentally, by definition, patient-reported, as well as the disease outcomes. So when you're in meetings where they're lamenting the patient experience scores, and then you come here and you hear about different ways, whether it's through physical activity, whether it's what we all share in common is just enhanced support around the person and their core family unit going through cancer. And you're seeing improvements in the symptoms that matter to patients. It's each of us, we're all in enough meetings where we can make that connection. And another point that you made that I want to put in a plug for, it's work that's actively going with Society for Integrative Oncology, SIO, together possibly with ASCO, that's still in discussion, but making the business case. I can guarantee you that no health system has gone under because of the music therapist, or the acupuncturist, or the massage therapist. Guarantee. We've made the business cases in our individual organizations. We're pooling that knowledge so that you're not reinventing the wheel. And the short answer is many of these rules either pay for themselves or have a negligible impact on the bottom line. It's usually 2 zeros less than the last investment that they made. Stay tuned and stay in touch, please. That's how we keep this going.
I think we do a few more minutes.
Oh, sure.
If there are, I mean, I'm not trying to hold us, but I think we have a few more minutes. But I did want to avail your expertise in integrative and oncology. In our region, the patient experience of integrative oncology often includes ivermectin.
Of course, never heard of it.
And so, how would you guide us as clinicians to keep our patients safe as they interact with integrative oncology, which can kind of mean a lot of different things?
Okay, if we're recording, we should stop right now. But no, I'm happy to go on the record for this. This is, when I say active point of conversation, this is like actively being discussed in multiple text chains with different stakeholder groups. I had a 1-hour unplanned conversation with a colleague who practices across the country, who posted a tweet about seeing somebody who had what could be curative cancer actually opt for an anti-helminthic approach. She, in that subsequent week, has received about 30 to 40 death threats. Just from a tweet that actually wasn't disparaging, wasn't disrespectful. It was merely actually just essentially sharing her anguish. That's not an isolated event either. So part of what we're actively doing within JCO Oncology practice is to actually aggregate. I say one pager, but I'm on page 3 right now, so we're working on it. What does a snapshot of the evidence look like? If you take all the personal opinions, viewpoints, it doesn't matter who you vote for, pray to, whatever. What's the preclinical evidence in this space? What's the clinical evidence in this space? And what does a conversation and communications guide look like? That's where we're actively debating by text right now. It's recognizing that patient autonomy is a cornerstone of medical practice and medical care in the United States. That's always been the case. Always been the case. It's recognizing that there needs to be an individual decision as a clinician, but also as a practice, clinic, and health system level decision on what are the risks versus benefits of providing ongoing care. You can communicate in an incredibly respectful way that there's some level of, there may be some difference being made in the mouse models and in the petri dish. We don't have the kind of human information that we would want to say that something could actually help. Notice how I didn't say that this is wrong. No rolling of the eyes, no dismissiveness, none of that. We just simply don't have the quality of evidence that we would want before we recommend an intervention. So communicating that as such. And then what you do after that is going to be an individual and a practice level decision, which is, I want you to keep, so a couple of options. The one I choose to go with, and that's a choice, is I want you to keep telling me what you're thinking about and more importantly, what you're taking. We have to know that in the context of your cancer treatment. There was a study 6 months ago about how cannabis increases asymptomatic AST/ALT elevation, asymptomatic. So if your patient is taking cannabis and you have an unexpected bump in the LFTs, we have the standard things we think of, right away, and workup we need to do, but you actually kind of have to know whether they're using any form of cannabis. And because if you stop that, there's recovery within about 4 weeks. So I give that example to say the approach I take is, I want you to keep telling me what you're using. And then we'll talk about it like we do with any other cancer treatment, risks, benefits, alternatives. And you tell me what you decide, and I'll tell you how best I can support you. There are those who take it concurrently, a ton of folks. We're seeing some bumps in liver function that's coming together as essentially a case series right now. But we're also wanting to, there are also clinicians and practices who may say, if you're going to opt, if those who opt alternative versus complementary, who opt for a non-traditional approach versus what would be considered standard of care, we have to decide as a practice what kind of ongoing care can we provide them. Can I keep doing lab checks periodically? Can I, how do I make sure that the door is open? Do we want the door to be open? Those are all very individual decisions. But patient autonomy has always been central to our practice meaning our medical practice in the United States. That is really no different. That's really no different. Is that too soapboxy? It's expert opinion. Category E or Q of evidence. What else? But please don't have any angst over that. That's my clinician well-being hat. There's quite a bit of moral injury we incur when what we see as the right thing to do is actually the one that can't happen. Whether it's insurance denial, or whether it's patient can't afford the co-pays, or whether it's they want to take ivermectin. That moral injury is one we have to actually proactively mitigate by recognizing that patient autonomy is exactly what it is today as it's always been. And we're truly serving as the messenger, not the mediator of decision making. Okay.